people will join us also later. So, hello, dear colleagues. Thank you for joining us and welcome to the series of educational webinars from the Psychopharmacology and Psychosocial Wellbeing Working Group. I am Alisa Kamalyan from Armenia, co-chairing this group with my colleague Ayushi Kaneja from India. Our Psychosocial Wellbeing Working Group strives to be a platform of connection for psychosocial professionals working worldwide to improve the quality of life for children and their families by promoting a multidisciplinary approach to the psychosocial aspects of pediatric cancer treatment. And one of the ways of achieving this goal is educational webinars with specialists with different backgrounds. And today's topic is psychopharmacology in pediatric cancer. And it is my pleasure to introduce our speaker, Dr. Andrew Elliott. Dr. Elliott is a pediatric psychiatrist at the St. Jude Children's Research Hospital. Thank you, Dr. Elliott, for accepting our invitation. And floor is yours.
All right. Thank you so much for having me. I'm excited to be able to talk to everyone today about psychiatric issues in pediatric oncology. Can everyone see my screen now? Yep.
Yes, we see it.
All right. So I have no financial disclosures or arrangements that would be considered a conflict of interest, and our main objectives today are just to understand some of the common mental health concerns in pediatric oncology and when and how psychopharmacology could potentially help, and then how to navigate different barriers to treatment. As we all know, children come into a cancer diagnosis already with many different biological, psychological, and social stressors and situations that may influence their care and that their care may influence. Even prior to a cancer diagnosis, children might have areas of stress in each of these. And I tell many patients that they may never have needed to see a psychiatrist if they hadn't been diagnosed with cancer. And we also talk about the situation being so different than their normal day-to-day lives prior to diagnosis that we're really addressing what's going on with them in the here and now. And we'll have to put off what normal life is after their cancer is in remission if we get there, which hopefully more and more we are. So for biological factors, these can include things like the child's general growth and development and which can be impacted by cancer, such as loss of vision from retinoblastoma or losing a leg to Ewing sarcoma, as well as treatment side effects, which become a major player in a patient's well-being, with many treatments like high-dose corticosteroids more directly impacting mood and behavioral changes. Further, any existing medical diagnoses may be even harder for a child to manage when they're tired, nauseated, and exhausted from everything they've already had to do in their cancer treatment. Psychological traits like a tendency toward anxiety can develop into something more impairing as well. Even typically minor and expected anxieties like an aversion to needles can become more impairing when a child must have injections and blood draws closer to daily than just once or twice a year. I always think of taking my 5-year-old for her yearly vaccinations and putting one leg over her so she can't squirm too much or get hurt. But if you're doing that every day, then that's a whole different level of trauma that a child may experience, depending on how anxious and how they react to those medical procedures. Additionally, social stressors are often present in the loss of family and peer relationships when a child begins treatment. Financial stressors, increased demands on caregivers, and potential destabilization of other relationships really important to the child can intensify that child's own pre-existing and cancer-related stressors. And many parts of the cancer journey really cross-cut all of these areas. For many patients, losing their hair is a devastating loss. It physically and visually represents that they're ill and different, and it may make them feel like they aren't themselves, impact their self-identity, and it may be socially isolating. And that's an experience shared by many, many of our pediatric oncology patients. So what is psychiatry's role in supporting children and families? Alyssa's kind introduction already put out the importance of multidisciplinary collaboration. And At St. Jude, the resources we have encompass many of all of the groups listed here, but that may look different in different hospitals. Many hospitals don't have immediate access to a child psychiatrist, let alone a faculty member in psychiatry. And prior to my coming to St. Jude about 10 years ago, our access to a child psychiatrist was only a half day once per week. And it's hard for me to imagine now how people would manage with such little access to psychiatry, and similarly to all of our psychosocial services. In situations where resources are plentiful, including child life, psychology, social work, and many others, our main role as a psychiatrist may be evaluating and management of mental health concerns, specifically using psychiatric medications when they're indicated. But if a psychiatrist isn't available, that role might be played periodically by a neurologist or an oncologist. And in situations where psychiatry doesn't have a presence or that presence is really limited, other members of the psychosocial care team may really need to advocate for increased access to psychiatry and also be aware of some of the conditions that are typically treated primarily by psychiatry, like delirium that occurs in the ICU and acute mental status changes, and really push for their teams to take that seriously. While I'll mainly talk about how I go about treating patients with concerns that might require psychiatric medications, medications are always just a piece of a larger puzzle, which also includes the other medical and psychosocial team members who treat a child's cancer directly and support children and their families through social supports, therapy, spiritual support, and many other ways. And we always want to keep patients and families in the center of our collaborative efforts. Some of the main consults I receive as a child psychiatrist working at St. Jude include concerns with adjustment to illness, depression, anxiety, and even attention deficit disorder. Additionally, I get consulted on specific adverse effects of some cancers and their treatments, which might require psychiatric support, such as children suffering from posterior fossa syndrome and specifically the cerebellar cognitive affective syndrome component, delirium, and corticosteroid-induced affective disorders. All of these things are usually recognized the quickest when mood or behavior impacts cancer-directed therapy, though. Another huge role of all psychosocial providers is education, and that's the L of consult liaison psychiatrist, which is what many psychiatrists working in pediatric oncology identify as. And we can provide that education and kind of extend our supports through direct one-on-one education specific to a case, or in response to specific questions from other providers, through more formal education like lectures, seminars, and trainings, and through policymaking. At our hospital here at St. Jude, I've helped in reworking our behavioral restraints policy, implementing a behavioral emergency response team to help avoid having to use physical or pharmacologic restraints, and several other programs and educational pieces to just spread knowledge and increase awareness of things that we can all do to help children navigate their cancer journey. So there are some general overarching concerns with prescribing any medication, especially in an oncology or complex medical setting. So we'll go through those first, and I'll talk about some more specific areas. First, as with many things in pediatrics in general, there aren't any US FDA-approved treatments for psychiatric issues in pediatric oncology, and many times there aren't even broad resources or consensus guidelines for how to treat specific conditions. There is a general consensus among psychiatrists working in pediatric oncology, though, that psychiatric disorders are underdiagnosed and undertreated and can significantly impact a child's ability to participate in care and to recover. Not only that, but there is evidence that untreated psychiatric diagnoses do lead to worse outcomes in many medical areas, some specifically linked to pediatric oncology, such as depression being linked to higher morbidity and mortality in recipients of pediatric bone marrow transplants, and untreated delirium in general, wherever it happens, is also correlated to longer hospital stays, higher costs, and higher rates of impairment and death in those who are never recognized or never fully treated. Given these complex patients and overlaps between medical and psychiatric treatments, providers may end up prescribing outside of their fields as well, or at least needing to be aware of the impact some medications from other specialties have, intended or not, on their own treatment plans. It's happened more than once where I've talked to our neurologists who were using a drug like levetiracetam to control or prophylactically treat potential seizures after a surgery or another condition made them concerned for seizure activity. But while levetiracetam doesn't have that many side effects, the one it does have is making children sometimes incredibly irritable and sometimes aggressive. So it may not always be the best choice when we notice that that is happening. Additionally, oncologists may consider using a antidepressant medication to treat mood, or they may consider using a drug like olanzapine for its role in decreasing chemotherapy-induced nausea and vomiting, and sometimes also getting comfortable with it and using it for mood concerns or sleep. So having a general knowledge of how these medicines work and when you would use them and side effects to look out for is important. So there are many concerns that might need to be considered before prescribing a medication to treat psychiatric symptoms or diagnoses in pediatric oncology patients, like will this drug interact with any current treatments the patient is receiving? And since many treatment plans are long planned out protocols, will the drug interact with any future treatments they're receiving? And will the drug significantly prolong the cardiac rhythm, putting children at risk for arrhythmias? Are there associated risks for delirium, concerns with drug absorption or liver metabolism? And overall, does pharmacologic treatment have a greater potential of benefiting the patient than causing them harm? And anytime we're in doubt, it's a good idea to either give some time, watch and wait, or start low with medications and go slow. Part of that depends on when we're first seeing patients and how severe the situation is. There have been times when I've been consulted for a patient that only learned they had cancer a few days ago, and if someone is suicidal after that, then it makes sense to get everyone involved and all hands on deck quickly. But sometimes it's just a provider being concerned and worried about the level of distress someone had on initially finding out about their cancer diagnosis. And that is a situation where we usually just want to wait and provide some psychosocial supports rather than jumping straight to medication management. The question I often get from parents and AYAs is, isn't this normal? Shouldn't I be sad after being diagnosed with cancer, after being treated, after feeling really cruddy with all these treatments? And I can't really argue with that. It is true. I think it's reasonable on some level. However, there are times when your mood can seriously impact your ability to receive treatment or your quality of life. And when that happens, that is more the time when I feel like we need to get involved as psychosocial providers, giving support to help a child go through this period of their life. So I tell families the more important question is, do these symptoms impact your ability to get care and your chance of recovery in a significant way? And then we have to ask if it would be more beneficial to try using a medication than wait. In this way, we're often more concerned about symptoms rather than diagnoses, though I do consider both. We may not always meet full criteria for a psychiatric disorder other than maybe an adjustment disorder, but the bigger factor is how impaired is the child, and how much do we think we can benefit that by using medications. My mentor, Julie Kearney, who works at Memorial Sloan Kettering, summed this up probably better than I just did by saying she thinks about three things when thinking about whether or not she should prescribe medicines. First, side effects. With many cancer-directed therapies causing direct mental health effects, like corticosteroids, if we can't stop the medicine, then sometimes we have to add a medicine to counteract those effects. And that would be one area. Or if a medication is causing irritability or confusion, then we may have to treat that symptomatically or with an additional medicine until we can stop the offending agent. We also want to consider safety concerns, and that does not just imply suicidality, self-harm, or harm to others, but also if a child is so anxious we can't care for them, that should also be a concern about their safety. Um, if they end up being a more prolonged threat to themselves, if they have something like claustrophobia that prevents us from getting a reasonable MRI scan, then we can't treat them effectively without that. So that may be a time when we want to treat. We also want to consider their suffering. There's both acute suffering, like the frightening hallucinations of a delirious child, or the inconsolability related to steroid-induced affective disorders, but there's also the suffering that can occur through things like achievement gaps in learning when a child has untreated ADHD and they're trying their best to participate in school, but they just cannot meet their potential. Or they're constantly getting told to stop by their parents when we're also asking them to sit in waiting rooms for hours at a time. When possible, we will also symptom cluster some of our medication choices, and that can help for several different reasons. Sometimes it makes it more palatable to parents if we say we're treating both depression and neuropathic pain by using duloxetine, or we know your child isn't eating, we know they're not sleeping, and of course that's impacting their mood. So maybe we should start something that can help with all three of those by using a medicine like mirtazapine. So while those medicines might not always be my first choice, if I was treating just depression or just anxiety, when we have multiple different things going on, it may make sense to use one medicine to target multiple areas. And I mentioned earlier that olanzapine is sometimes prescribed for issues outside of psychiatry. And part of that is because recently, in 2017, I guess it's not so recent anymore, the American Society of Clinical Oncology added olanzapine to their algorithm for chemotherapy-induced nausea and vomiting in adults, and that's been extended to be used for children as well. Some evidence exists, though less, that other medicines known of as antipsychotics may also help with chemotherapy-induced nausea and vomiting, but olanzapine is the only one that I'm aware of that's made it into treatment guidelines. And to many, including myself, it makes sense to use olanzapine in an oncology setting more so than it would outside of one, because there are many issues that its otherwise troubling side effects can help. It can help prevent nausea and vomiting, but it can also help kids get to sleep a little bit better, and it can help really improve appetite. One of the big detractors of prescribing it outside of an oncology setting is it often makes you gain a lot of weight, but it's not that common that I hear parents complaining that their child is gaining too much weight, or at the prospect of them gaining a little bit of extra. Additionally, effects of olanzapine are usually pretty rapid as well, and we often want to see change quickly. Many of our other medicines for treating anxiety and depression don't work as quickly. They may take weeks to months to work. And sometimes, if someone's having immediate impact to their ability to receive care now, then having something that could work quicker makes sense. As you can see from this chart, this data is a little bit old, which we plan to renew soon, but Psychiatry was not the primary prescriber of olanzapine in 2016 and 2017, and I'm pretty certain we're still not the primary prescriber of olanzapine, which would be strange to a psychiatrist not working with oncology patients, but that is kind of where we're at here for those specific uses. It's also used in big things, so if a parent looks it up, they're going to see schizophrenia and bipolar disorder, so we try to remind them that is not what we're using it for. But we also need to remember that this is a pretty big gun, psychiatric medicine, so it can cause a lot of significant side effects that if we're prescribing for nausea, we need to be aware of, like extrapyramidal symptoms, which are also known as Parkinsonian symptoms. So if you have symptoms that look like Parkinson's disease, you may be experiencing these. And those include like muscle stiffness, a stereotyped gait, akathisia, which is kind of an inner feeling of restlessness, similar to restless leg syndrome if it never went away, and tardive dyskinesia, which are repetitive movements like chewing in small muscle groups. And tardive dyskinesia is one of the most concerning because even if we stop the medicine, it's not guaranteed to go away. And while the risks of all of those are very small, we still need to be aware. We need to make parents aware of what these things are so they can be on the lookout. Um, the more common side effects are weight gain and a potential increased risk in metabolic syndrome and diabetes. So we need to watch that as well, especially when we're using this medicine or other medicines like it in children who already have risk factors for weight gain, like being treated with steroids. Oh, one other thing here. Um, since this medicine and others can be used for multiple things, anytime we're using a medicine for sleep and anxiety and nausea or multiple factors, we need to be clear what the primary reason for treatment is because we don't want to look back at a chart from someone who's gone outpatient and inpatient and outpatient and inpatient and then realize, I don't know if they have schizophrenia or if they have difficulty with nausea or if it's difficulty sleeping. We were just trying to augment their antidepressant. So it's important to be clear on what the primary indication is when using one of these medicines. So you also know how to balance the risks and benefits of continuing versus stopping it. So now I want to just quickly discuss several more specific areas and conditions in a little bit more detail. First, the most common thing that we will all probably see is psychosocial providers is depression and anxiety, which is common in pediatric cancer patients and is just common in pediatric patients on the whole as far as mental health conditions go. Patients who have symptoms but don't meet full criteria for a mood disorder like major depression or generalized anxiety disorder are often given the diagnosis of adjustment disorder. And that makes sense per the ICD-11 classification, which defines adjustment disorder as a maladaptive reaction to an identifiable psychosocial stressor or multiple stressors, including illness, that emerge within a month of the stressor and may continue and then resolve around 6 months unless the stressor persists longer, which it often does in many of our treatment protocols, which can last years. Patients are typically preoccupied with that stressor or its consequences, with worry, distressing thoughts, or rumination, and do not adapt well, resulting in impaired function. And when I think of adaptation, I think of adaptation to your current environment. And if a child's current environment is being a patient being treated for cancer, if they can't take medicines, if they can't show up for medical visits, and if they are petrified with the idea of getting a scan or a poke, then they have impairment, even if it kind of makes sense for some kids at their age level to have that impairment. So it may be something we really want to address. It's also important to know that children may show symptoms of anxiety and depression differently, and that's something that we need to stress with parents and our other colleagues because children can be less social. They can be more irritable or aggressive. They may stop sleeping. They may be more hyperactive. And often the people that they take out aggression on, regardless of the cause of aggression or irritability, is the people they're closest with, their parents. So letting people know, like, this may be anxiety that we don't recognize. We just recognize this child is screaming and yelling at us, and that doesn't mean they're a bad kid. It means that they are incredibly stressed and don't have a better way of coping with these feelings that they're having in this really intense situation. So, as I said earlier, we really want to look out for things that impair our ability to treat a child's cancer. When we're looking at reasons to pursue treatment for mental health conditions. Some impacts on cancer-directed therapy can be poor adherence to treatment. A depressed or anxious patient may just be less adherent to recommendations, or they might just not feel like taking them or be too anxious to work with physical therapy. They may push parents to skip medical appointments or try to sleep through them, and some patients may be much more irritable and even aggressive when they're experiencing a depressed or anxious mood. And that can come out when a provider is trying to get vital signs or trying to speak to them about what symptoms they're having. And here, treatments can help. Psychotherapy and behavioral interventions are important, and pharmacotherapy can have a place in addressing mood symptoms in these patients too. This is a list that I won't go over fully, and it has a lot of detail on it that may or not be pertinent depending on your role. But some of the most common medications we use for longer term treatment of depression and anxiety are the SSRIs, which do take about a month to work with daily dosing, but are some of the best and most effective medications with the least side effects when we're trying to treat longer term anxiety and depressed mood in our patients. We'll sometimes use medicines like amitriptyline or duloxetine when we're also concerned about helping with low energy, neuropathic pain, GI distress, or even some attention difficulties with bupropion. But we also sometimes are in situations where we need something to work now, not in a month. We try to plan as best as we can, but if someone is having radiation therapy on a daily basis, and it's either sedate them every day or treat some claustrophobia or procedural anxiety, it may make sense to give them a pre-radiation dose of lorazepam for that specific trigger of anxiety. And if someone is incredibly anxious and doesn't have a specific and time-limited trigger that we can predict, then we may treat with a medicine that's a longer-acting benzo like clonazepam, and it can serve sometimes as a bridge to effects of more long-term antidepressants like escitalopram or sertraline. We will occasionally use drugs like olanzapine and quetiapine to boost the effects of antidepressant medications, and because they will work much more quickly, but they're not an ideal long-term solution. Also have haloperidol down here. I thought I'd erase that one because it's really not used in depression and anxiety, but it's one of the few medicines we can give for immediate agitation and irritability, and can be given in ICU settings as well when patients can't swallow a medication or are not safe to swallow a medication by intramuscular injection or IV. More than anything, this medicine is reserved for things like delirium in ICU patients and for acute agitation. So just a general summary, kind of a larger picture summary of how we would treat depression and anxiety are that depression and anxiety can occur in our patients, and they can seriously impair cancer-directed therapy and quality of life. For longer-term management of depression and anxiety, especially when it doesn't occur only in isolated, predictable situations, SSRIs like sertraline and escitalopram are typically the best way to go, taking particular attention to drug-drug interactions that they may have, which is part of the reason I boiled it down to those two SSRIs, because they have fewer than some of the other ones like fluoxetine or paroxetine. If we need to consider other symptoms like pain, sleep, or impaired cognition, we might consider other maintenance type meds such as TCAs, SNRIs, or NDRIs, but we need to be aware of their different side effect profiles because many have a different set or more risk of certain side effects than SSRIs. And when we need treatments that work quickly, our best options might be those benzodiazepines, like lorazepam for acute procedural anxiety or clonazepam for more generalized everyday anxiety that's impairing treatment. I've also sometimes found that things like anticipatory anxiety can be treated with drugs like olanzapine because there's both an anxiety component and a nausea component. And using drugs like these can give us more rapid control while we further work and provide non-pharmacologic supports as well. So steroid-induced affective disorder is something that I feel like it's not entirely unique to psychiatry, or to pediatric oncology, but because we use such high doses of steroids in our treatment plans, it is not uncommon. One teenager once shared this quote with us: steroids make me feel like I want to hug someone and slap them at the same time, which really kind of sums up the feelings that many of our younger patients can't put into words. Corticosteroid medications can make you angry, restless, and incredibly uncomfortable, and there's really not a coping skill that helps calm those feelings in many situations. So kids are left trying but not succeeding to deal with these medication-induced mood disorders, and sometimes not even knowing why they're happening. While younger children may have a harder time putting it into words, these mood changes don't spare them, and even very young children and toddlers may be completely inconsolable while on steroids, and their parents are left feeling pretty helpless to help them. So as I said, administration of steroids is pretty common in several types of cancer like leukemias and lymphoma, where they might be used in pulses for months on some of the St. Jude treatment plans we use. And they can also be used for CNS swelling and inflammation. As my previous quote implied, they can cause some pretty impairing symptoms, and I've sometimes just thought of them as almost a psychiatric grab bag because they can cause psychosis, not as commonly as other symptoms, but they can. They can cause confusion, agitation, inconsolability, and mania. And they can vary in which symptom they cause with different pulses or different time periods. But by far the most common symptom is mania, especially with a more irritable or inconsolable presentation. Longer exposures, though, seem to increase the rates of depression. So when we've had children on corticosteroid pulses for months or years, as we do in some ALL patients, then we might notice a gradual shift towards more depressive symptoms. One study of those receiving systemic corticosteroids showed that 6% had severe side effects and 28% had mild to moderate effects, which adds up to over a third of patients having some negative psychiatric effects of corticosteroids. And that was in pediatric patients, but we've known for a while that steroids cause psychiatric symptoms, and we've also known that they've been dose dependent. The Boston Collaborative study way back in 1972 showed that rates went from 1.3% at relatively low adult doses of steroids to almost a fifth of patients receiving doses higher than 81 milligrams in that high dose range. When someone is developing these side effects, they generally occur within a week of initiation of treatment and may resolve fairly quickly after corticosteroids are stopped. In cases with more manic, irritable, inconsolable presentations, we use medications like olanzapine, risperidone, and quetiapine as our mainstays of treatment. In addition, psychoeducation is really important for families because children and parents need to have some understanding of what's happening and not just have this idea in the back of their heads that they're going crazy. They need to know that this is a medication side effect, that it will resolve after the steroids are stopped, and that if it's severe enough, there are things that we can do to help. I've talked to several parents who have been up for multiple days with their 1 and 2 year olds who have constantly cried, having only minimal success in calming them down. And a few of these were parents whose child had just been diagnosed with cancer, so they didn't know that this was a med side effect and might have thought, is my child in horrible pain? Is something else going on? Is my child dying? Because the presentation with our youngest kids can be really jarring and intense, a different level of inconsolability than we would have with most young children and toddlers. So while psychoeducation is important, I also wouldn't be shy about asking your pharmacy to prep a tiny dose of quetiapine solution, like 6.25 milligrams or a fourth of the smallest pill, even for a 1 or 2 year old that is having this much distress. While there have been other options proposed, and with some effect, things like mood stabilizers, including lithium and Depakote, have more side effect potentials in the short and long term than some of the antipsychotic medications. So I typically try to avoid them. We can try a steroid dose reduction, and I've also seen some providers shift their corticosteroids to increased methotrexate dosing for this and other symptoms. We've also had previous research in a small pilot study that suggested that hydrocortisone co-administration would diminish these side effects. But when those researchers collected more data, they found no benefit from hydrocortisone. So I think it's important to know that while we thought this was one of our other options, it really has not panned out. And if this is a topic you're interested in, or you're seeing lots of different cases of steroid-induced affective disorders, one of my close colleagues and I recently published this article, How We Approach Steroid-Induced Affective Disorder, which is a case series of 3 different patients we've treated, and share some recommendations on both pharmacologic and non-pharmacologic things that we would do, and how we approach these cases. Steroids are not the only thing that cause psychiatric adverse effects. Things like cranial radiation, especially whole brain radiation, can cause deficits in attention processing, attention processing speed and working memory. And as I've said, Keppra can cause irritability and aggression. We also have things like ifosfamide. When someone becomes toxic with that, it can cause confusion, hallucination, drowsiness, and coma. So we need to be aware of these other potential adverse effects. Another effect that we're regularly trying to balance is effects on the cardiac rhythm and QTC, one of the areas that we measure when we're assessing the length of the cardiac rhythm, because many psychiatric drugs and non-psychiatric drugs can prolong this. And if someone is on a treatment protocol where they have to stay under a certain QTC, or they get to an area where we think that they might have a really serious adverse reaction, the first medication we stop is likely not going to be their opiate, and it's not going to be their chemotherapeutic agent. The first thing we will try to probably get rid of is the psychiatric medicine. So I try, when possible, to choose some of the least offending agents, which are listed at the bottom here, with the ones in blue being the least associated with cardiac QTC prolongation. Delirium is another area where I think all psychosocial providers, really all providers, need to be aware and monitoring for, because since delirium's presentation can wax and wane, we need multiple people to be observing and monitoring for this. Just as a refresher, delirium is an alteration in mental status that is caused by a medical condition, treatment, or a combination of many conditions or treatments. It often does wax and wane, and it presents as an acute onset change in mental status, often with disorientation, irritability, agitation, or withdrawal, in a more hypoactive presentation, where a patient may just stare at the ceiling for long periods of time or have very diminished interactions. And it is most likely to occur in the very young, the very old, and the very sick, which 2 out of 3 affects our patients there. There are multiple potential contributors to delirium in pediatric cancer. Our kids are often on many medications. Many of those are well known to be risk factors for delirium, like benzodiazepines and antihistamines. It is not uncommon for them to be critically ill and require ICU hospitalizations, sometimes extended hospitalizations. And while there, they may have really limited mobility, disrupted sleep, and pain, and just being in an unfamiliar environment, which is exponentially compounded when we bring patients to St. Jude from different countries, and they shift between different hospital areas in an environment where no one speaks their language. So we need to be aware of these things and aware of the stressors children and their families are facing, and get a good baseline of what their mental status should be so we can better interpret when there's been a change. There are not too many studies specifically on pediatric patients with oncologic diagnoses and delirium, but one I found from the University of Arizona took 70 patients with cancer in a retrospective chart review and found that 7 had at least 1 episode of delirium, which is 10%, and of those, 2 of the 7 patients died. Hospital stays for delirious patients were also longer, averaging about 3 times higher than those who were non-delirious. And the authors of the study suggested that given this was a retrospective design relying on other providers to recognize the delirium, it was probably significantly under-recognized in this study. So when treating delirium, the biggest piece is identifying the cause, the medical cause, and treating it, whether that be sepsis, fever, end organ dysfunction like acute renal failure. We have to recognize that and treat it aggressively. But psychiatric medications, as well as environmental interventions and psychoeducation, may help. They don't cure delirium, though. We'll talk a little bit more on the non-pharmacologic interventions we can use, but the pharmacologic ones are often used for symptomatic treatment to ensure safety, primarily in our hyperactive cases of delirium, where we're concerned that patients may pull out a line, a trach, or try to get out of bed and have and fall, or if they're being aggressive or just acutely scared because they're having hallucinations of bugs crawling around the room or feel like something awful is going to happen to them due to delusions or paranoia. Additionally, while we really attempt to avoid physical restraints at all costs, they may be necessary in some patients if we feel like there's no way we can get back an airway if they remove it, or if they're going to hurt themselves or staff and cannot be managed with medications first. Still, physical restraints are always a last resort, because if a person doesn't really know where they are and they're confused and they wake up and they're also tied to a bed, then it will not help their confusion. And it would not be unreasonable for a person with that mental state to fight against those restraints, putting them at risk for more injury. So how can we help overall and help parents feel like they've got a role in helping when a child is delirious? The first thing is we want to promote good sleep hygiene and a reasonable sleep-wake cycle by minimizing unnecessary nighttime disturbances. If we can convince people that vital signs aren't as necessary when they truly aren't, then we should go in the room less. If we can promote increased activity and mobility during this day, movement and activity do help to decrease delirium. And avoid disturbing events or media when a patient is in and out of consciousness or confused or sleeping. We also want to manage pain, recognize and treat drug withdrawal, and if there's a way to reorient patients and to make them feel more at home by providing a familiar object or consistency in caregivers, we should do that as well. With these patients, or really any kid in the ICU, I think it's also really important to remind their caregivers that they need to eat, sleep, take breaks, and we need to find ways that they can feel helpful for their child too, but not at the expense of their own well-being, because they can't care for a child if they can't care for themselves. There's a lot more information on delirium at the website listed in the bottom corner here, called icudelirium.com. And I would encourage you to look at that site. It also provides some free screening tools that you can implement at your own hospital if you would like. I'm going to quickly talk about posterior fossa syndrome as well, which originally covered a large constellation of symptoms occurring after surgical resection of tumors in the posterior fossa, which are often medulloblastomas. These symptoms include mutism, ataxia, mood changes, and emotional lability. And that specific emotional subset of symptoms has been called cerebellar cognitive affective syndrome. Patients with cerebellar cognitive affective syndrome can be quite impaired, but not all patients develop it at the same level or at all. And my experiences have included a child who essentially screamed constantly for several weeks, at least when not sleeping, to the extent that I really doubted his mom when she was telling me this, because it just could not be true that a child screamed this much and was this uncomfortable. And that was a severe case that we were able to control with both first medications and then therapy. I've also had kids who were incredibly perseverative on their immediate needs and wants, and flexible and unable to be redirected for more than a second or two due to memory impairments, and suddenly unable to understand the emotions of others. And with that, we have parents who are waking up, having their kids wake up a different kid, and we need to help educate them that these are not bad kids, and that they need therapeutic supports to adapt, and will often get better over time, but that may take months or years in some cases. We may use psychiatric medications when symptoms are severe here as well, like atypical antipsychotics for mood lability, or an atypical presentation of psychosis. We may use benzodiazepines for anxiety relief. There are some future investigations into using transcranial magnetic stimulation, and in my own practice, for just the impulsivity and unpredictability of some of these behaviors, a medication like guanfacine, which can kind of tamp down the physical responses to stress by uh, reducing heart rate and blood pressure, has seemed to help. And I've also had some benefit with SSRIs. So some key points are that our pediatric oncology patients come to us with pre-existing stressors and then cancer, and their cancer-directed treatment can put even more stress on their psyche. That increases the risk of emotional and behavioral disturbances that may impair their treatment, quality of life, and even likelihood of survival. And therefore, we can't ignore mental health symptoms. But it's important that we also know the risks and benefits of possible treatments and individualize our responses to the needs of our patients when possible. Due to a lack of mental health providers, oncologists may find themselves treating some of these conditions themselves as well. And so I hope this has given you a bit of insight into how to approach some of these issues, and that psychiatry can play a role in caring for our pediatric oncology patients. And for my oncologist colleagues, remember that when psychiatrists are available, we rely on you to help us in getting a good idea of what the risks and benefits are of psychiatric treatments and how they fit in with your oncologic treatments. So with that, I have a few cases, but before we do that, since we don't have a lot of time, I'd like to open it up for questions instead.
Yeah. First of all, thank you for this excellent presentation. I believe it's very useful for all of us. Actually, we have two questions.
Mhm.
One is a request of, could you please share with us the research paper link?
Yes.
I guess the paper about steroid-induced affective disorder.
Absolutely.
We can later send it to the group when you share it with us.
Okay.
And second question, if you could recommend any screening diagnostic tool for delirium? Question from Asma Kasana.
Yes. So I can do both of those things. For delirium, if you go to that icudelirium.org website, they will have two different tools. They're the primary tools that are used for assessing delirium. One is the Cornell Assessment of Pediatric Delirium, the CAPD, which is a nursing-driven screener for delirium that occurs with kind of a longitudinal assessment. So during a nurse's full shift with the patient, which is usually 8 to 12 hours here, then they will just observe the patient and their interactions. They don't have to really ask them anything outside of their normal questions, but they gauge whether the patient has interacted with them. They can voice their needs. They make eye contact. It's also been listed with developmental anchor points because delirium can happen in kids that are less than 1 and may even be more frequent in the very, very young and the very, very old. So it's important to have a way of assessing that and responding. That after nurses have completed their shift, they answer this, I believe, set of 8 questions, and that will give you a score that's a basic screening for delirium, and then you can go in and look more closely. Since these are screeners, we want the sensitivity to be high. We want them to catch almost all cases of delirium. So sometimes it may not be a delirium, but at least it gives you the opportunity to go and investigate further. The PCAM and PSCAM are the pediatric confusional assessment. I can't remember if it's method or what the M stands for, but basically it's a tool for assessing delirium in pediatric patients. And it is in the pediatric form and the preschool form for younger children. And that is a more point in time scale where you go in as a provider, and really even a parent can do this if you want kind of a longitudinal assessment. It's not a complicated scale. You just have to know, has there been a change in mental status? One, is that change waxing and waning? Can a patient show persistent attention? And oftentimes that is either through looking at cards, like picture cards if they can't talk and verbalize, and squeezing your hand if they see a certain card. Or if they're very, very young, just tracking if you're moving a card across their line of sight. If a 1-year-old is seeing that and they're awake, they should track that with their vision. They should track their caregiver. If they don't and they stare straight ahead, then we may be concerned about delirium. Children that can respond to questions can also be asked yes, no questions, which even if they're intubated, they can squeeze a set of fingers. And asking really simple questions like, is water wet and is the sun hot, are some of the ones suggested in that section. The ICUdelirium.org site has those on a pocket card, so you can carry them with you if you want to, and they have a couple of videos showing what a positive screening looks like in children. So it's a really helpful site, and I will send the link to that paper as well. Any other?
Yeah, if you could put it in the chat, that would be great.
Yep.
While you're tapping, there is another question from Ayushi. Is age of the child patient is important criteria to consider pharmacotherapy?
Yes. In some patients or in some conditions, maybe less so. We don't have a lot of information suggesting that. Unshare real quick. We don't have a lot of information suggesting that depression and anxiety in children, preschool age children, can be treated super effectively with antidepressants. And there's not a lot of data to say even children who have had chronic stress could have brain changes. I think it's an area that would be really interesting to research, but typically we want to change the environment and provide family supports and direct therapy for those children under 6. However, if the behavioral change is more related to a specific medicine, like if a child is on corticosteroids and that is really ticking off their amygdala, causing all kinds of mental health concerns, that is a biological change caused by a medication. So if we can't stop the steroid, which would be the ideal thing if all other things being equal, then we may need a medication to stop that behavioral change. And if a very young child is incredibly distressed because they're delirious, it may not matter if we can't care for them, their age. We will just be extra cautious with the medication choice and the dosage in those very young children.
Thank you. We don't have any other questions in the chat, though people can unmute themselves and ask questions verbally. Let's see if we have. Yeah, thank you for sharing the link.
We've got just a little more time and waiting for questions. I can try to go back. And actually, we don't even need the slides for this, honestly. But one of the cases that really hit several different areas and how pediatric oncology is so different is when I had a 6-year-old who had, before she was diagnosed with cancer, had a prior history of some severe physical and sexual trauma. And during her treatment, she became really seriously physically and verbally aggressive during stressful and painful procedures. She injured a caregiver, an older relative, and she also hurt several staff members due to this trauma. And knowing her therapy for acute lymphoblastic leukemia would last at least 2.5 years, and even after a few weeks, we were feeling overwhelmed as a treatment team. We debated, how do we help her? We asked if trauma therapy would initially worsen her aggression. Even if we tried, could we make it work? Could she get to intensive trauma therapy while she was also completing chemotherapy? And then would blood draws and other procedures further worsen her trauma? Because we're holding her down for those procedures. We're sticking her regularly. And that is something that happened to her without any permission by loved ones, just hurting her previously without any real reason. and how could we instill a sense of safety in a child who had had this previous trauma, that had never really known safety and trust of her caregivers before us, and the caregiver that stepped in, the relative that took care of her. And we were really lucky in this case. We thought for sure more people were going to be hurt, that we would have to discontinue care. But we did, after that first couple of weeks, refer her to trauma-based therapy. And this older relative who was taking care of her took her diligently, called me from the parking lot of the trauma-based therapy location on the phone saying, she's in the car, she's screaming, she's trying to kick the windows out. I just want to know that when the police come and ask me what the hell I'm doing, that someone will be on the phone to tell them I'm not trying to abuse this child and what's going on. But this woman was amazing, and she took great care of this child. We did need to use some medications to help her get through her treatment, partly just to sedate her through some of it, and also to help with some mood lability. But after completing trauma therapy, she became much less aggressive, helping people understand where it came from. Staff, especially, really helped them to kind of deal with their feelings towards the situation. And she was able to complete her therapy and is now happy and healthy and back at school doing her young, now 8-9-year-old thing.
Yeah, we have the comment that this was an insightful session, and thank you.
And then
So,
Asma, I see, also asked, excuse me, about prescribing medicines if children are not willing to take them. So that is difficult. And it partly depends on the context. I have had parents who have snuck medications in on their child in their food or yogurt, and I don't love that. If they're very, very young, then I may allow it in certain circumstances because that child doesn't have the ability to really understand what's going on. But typically, we really try to avoid starting a medication, especially one that needs to be taken daily, in a patient that is just outright refusing them. I think it usually takes several sessions to get an idea of if we can, through building rapport and kind of destigmatizing mental health, if we can get a patient to agree that this is something that is at least worth trying. And one of the, especially with my young adult patients, the thing I tell them is, I have no desire to make you a zombie. I have no desire to force you to take something that makes you feel worse instead of better. And I will not be home with you putting this medicine down your throat. So if you don't want to take it, I can't make you. And your parent is probably not going to be able to make you either if you're 14, 15, 16. So I think just being honest with patients and trying to build that initial rapport and understanding that you're not saying that there's something wrong with them. You're just trying to help in a situation and they have control can be really important. Sometimes when it comes to mental health things, kids and parents have had so little control in cancer that they just need control of something. So if we can get them to say, yes, I want this, then there's much better chance that there's going to be benefit.
thank you. Yeah, I think we can. Thanks again, Dr. Elliott, for giving time to our group. This was really very helpful and insightful and very interesting and excellent.
Absolutely. Thank you for having me.
Thanks everybody for joining us today. For those who joined us late or did not manage to join, we will later send you the YouTube link of the recording of this webinar, as well as the presentation slides, which Dr. Elliott will kindly provide us. So follow to your emails. And our next webinar will take place in January, with Dr. Elise Heiderberg, who will discuss psychosocial assessment and interventions in pediatric oncology. So please join us on our psychosocial well-being working group to connect and WhatsApp to stay updated about our activities. Thank you, everybody. Yeah. So we have lots of messages saying thank you.
Well, I will send you that right now. And again, thank you for having me. And I hope we'll get a chance to talk again soon. Bye-bye.
Thank you. Bye-bye.